Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you so much for inviting me back. What I'm going to go over today there's no new data that I'm going to be able to share with you today about cabotegravir. I do think some of the recent PrEP guidelines and also some of the information that is part of the recent December 2021 FDA approval of cabotegravir for PrEP that's caused a lot of confusion and consternation, hopefully will be laid a little bit plain by the data that I'm going to review today. So that's my goal, is to contextualize some of the nuances of the findings in 083 that led to these somewhat controversial recommendations that RNA viral load testing is a requirement before starting cabotegravir and before providing each injection. And to be very specific, the FDA approved prescribing information specifically requires an RNA test that is FDA approved or cleared for diagnostics, which is limited to actually two tests, right? The hologic aptima test and the Roche HIV-1, HIV-2 qualitative test. That's it. So technically, if you follow the FDA prescribing information, it's virtually impossible to use. I actually don't think that that's necessary. I think a quantitative viral load with a lower limit of quantification of 50 or below is probably okay and is what most people are going to use. But I'll show you the data that sort of got us there. So these are my disclosures. I'm not going to belabor this slide, but anybody who's heard me talk about PrEP knows that I am completely enamored with this slide, because if you put up a table of PrEP trial efficacy results, everyone immediately starts checking their email or their Instagram. So I conceived of this sort of graphic to contextualize the tenofovir-based randomized trial PrEP results using this conceit as someone who grew up in the Northeast. Those of you from the Northeast of the U.S. know that around the holiday times, houses of worship like to have a big thermometer outside, and they do philanthropic fundraising, and they fill up the thermometer posted outside the house of worship to show their progress at completing their fundraising goals. And I thought that was a useful analogy, because what is depicted here is the sex at birth of the patient population is depicted by the character outline, and how filled up they are is the point estimate of the risk reduction for HIV in the active arm of each of these PrEP trials. And what I like to point out to people is you can understand why there was an enormous amount of consternation and confusion by both consumers and providers of PrEP when these data first were presented, because they're all over the map. Of course, the devil's in the details, and adherence was the number one predictor of the efficacy results, slightly modified by drug tissue penetration of this particular combination, allowing less forgiveness in the vaginal compartment compared to the rectal compartment. This was the context in which long-acting cabotegravir was developed, because of this observation of the need for adherence to get high levels of efficacy. Of course, we did also have some second-generation agents, the dapivirine ring, which now has EMA approval for cisgender women in sub-Saharan Africa, with estimates of about 30% in the randomized trials of HIV reduction, 50 to 70% in the follow-on counterfactual open-label extensions. And fascinatingly, the dapivirine ring was recently withdrawn from FDA review by the sponsor of that submission, IPM. So it's not going to get FDA approval in the US. Whether or not future iterations of this ring, probably a 3-month version of the ring, will ultimately be sufficiently robust in their data to support FDA regulatory approvals remains to be seen. But this ring is not going to get FDA approval. And then, of course, TAF FTC in the Discover non-inferiority trial got approval for sexual transmission for all routes except vaginal transmission. And the company that makes both brand name products of the branded TDF-FTC and TAF-FTC, sort of are positioning the TAF-FTC as a safer alternative, although, the data don't clearly demonstrate that, and the FDA approval is quite careful to not state that there is a superior safety profile and that they're just non-inferior in terms of efficacy. So in that context, we move on to PrEP 3.0. And so many of you sort of are familiar with dolutegravir from HIV treatment and its chemical structures in the lower right corner of this slide. And if you're a sort of organic chemistry heterocycle nerd like I am, you love these structures and you love looking at how cabotegravir in the lower left corner, here identified by its investigational name GSK 744, are similar and different structurally, but they're sort of chemical congeners of each other. They're both integrase strand transfer inhibitors. The lack of water solubility of cabotegravir makes it particularly amenable to preparation as a nanosuspension. And, a lot of people ask me, what's in the injectable version of cabotegravir? And the answer is it's actually just microcrystalline ground up the actual drug. So it's in a polyethylene glycol suspension, but the nanocrystals, the microparticles, are actually pure crystallized drug substance that then is injected into the body of the muscle where it serves as a depot and is eluted slowly over time into the bloodstream to provide sustained release. So the kinetics of the drug actually are determined by the rate of its leaking out from its depot in the muscle. It's actually rapidly degraded once it gets into the blood by UGT 1A1 and also to a lesser extent 1A6 and 1A9. So cabotegravir developed mostly for injectable suspension. It is available as an oral tablet for daily administration as well, but ViiV is not going to be seeking independent regulatory approval for oral cabotegravir as a PrEP agent, nor separately for use in combination treatment of HIV for people living with HIV. So just to remind people very quickly what the 083 study design was, these were increased risk cisgender men and transgender women who have sex with men who were HIV negative at enrollment, and that was defined by a negative rapid test, a negative fourth generation antigen antibody test, and a negative RNA test within 14 days of enrollment. Were randomized 1-to-1 to either the orange arm on the top or the blue arm on the bottom. The orange arm is the cabotegravir arm, the blue arm, the TDF-FTC arm. And everybody got a 5-week oral lead-in during that, because it was a double dummy study design. Everybody got 2 pills a day, 1 active, 1 placebo. And that was to establish the safety and the tolerability of the cabotegravir tablet product if that's what they were randomized to. It didn't really serve a purpose if they were in the TDF-FTC arm, but it was blinded, right? And we did have a requirement that at least by pill count, somebody had ingested 50% or more of those oral tablets to at least get a sense of tolerability before giving them the long-acting injection. That comes into play when you actually look at the FDA approval of the drug, which renders this oral lead-in optional, right? Which is a little bit of a surprise to me. I'm delighted that they made that decision, but there's fairly limited data in the HIV uninfected PrEP setting for that recommendation. It's really based on a fairly small number of patients in the FLAIR trial, which was one of the registrational trials of Cabenuva for HIV treatment, where some of the late switch people who were randomized to the standard of care arm in that trial were given direct to inject cabotegravir and rilpivirine rather than first undergoing an oral lead-in of both those agents, which was the other sort of standard in that protocol. So we don't have any PrEP data of direct to inject, but the FDA approval makes it optional. So that is important to know that it's actually not based on data in this population. Anyway, people who had sufficient tolerability and adherence in that oral phase went on to the direct oral injectable comparison, which was an injection every 8 weeks after initial 4-week interval between the first 2 injections, and a daily oral tablet. One was active, one was placebo. The sham injection was 20% intralipid, which looks and viscosity-wise is virtually identical to the cabotegravir product. So FYI that. People were followed for 153 weeks, which is ballpark 3 years. And if people stopped early, we covered the pharmacokinetic tail by giving people a year of open-label TDF-FTC for 48 weeks thereafter, and we called that step 3. So that was the study design. So going back to AIDS 2020, which unthinkably is coming up on 24 months ago, right when we were sort of entering the pandemic, the first wave, these were the results we presented, right? And this was sort of super exciting because it was a dramatic result. And hopefully you can see my cursor. These were incident HIV infections by the pre-specified HIV testing algorithm in the study. And I'll tell you a little bit more about what the pre-specified algorithm was, what we learned and why we changed it and why we're now presenting basically post hoc results and how that changed things. So what we thought we had was 13 incident infections in the cabotegravir arm and 39 incident infections in the TDF-FTC arm. These are the incidence rates per 100 person years in each arm. And on the right side of the slide, this is the hazard ratio. So there was a 66% reduction in HIV incidence in those randomized to cabotegravir compared to TDF-FTC. And you can see the 95% confidence intervals that not only excluded the pre-specified non-inferiority margin, which was 1.23, so a 23% relative non-inferiority margin was our pre-specified metric, but also 1.0, which would be superiority. And we also had an alternative hypothesis pre-specified in the study of a hazard ratio of 0.75. That is, we hypothesized that CAB would be 25% better because of the decreased need for daily adherence, and we excluded that as well. So this is clearly a superiority result. This was what we pre-specified, and of course the devil's in the details, and the reason I'm perseverating on this, of course, is this is going to lead us to this understanding of why the CDC and the FDA, and I do believe it's correct, to recommend RNA testing as part of screening when using CAB PrEP. So what was pre-specified on the left side is what the sites were doing. I told you what happened before enrollment, but at every visit, these participants got a rapid test and they got an instrumented laboratory-based fourth generation antigen antibody test. Behind the scenes, not done in real time, this was all done in stored specimens, we stored plasma at every visit. The HPTN Laboratory Center at Johns Hopkins did the following tests. They did a standardized fourth gen. They used the Architect platform. If it was positive, they did a confirmatory Genius. They did an Aptima qualitative RNA test. Now, Aptima, the Hologic Aptima, is moving from a qualitative only platform to a both qualitative and quantitative platform, right? I think everybody knows that. You can't get the only qualitative old version anymore. You can only get the new one, and it's a whole thing. But we had planned to do this qualitative test, and then we would back test from the first positive that the site had identified until it was negative once by Aptima. And by all previous sort of studies and concepts, that should have been enough to make sure that we were not masking HIV infection by having a potent anti-HIV drug as our PrEP agent. Of course, the TDF-FTC literature gave us a hint of this, but the problem with TDF-FTC PrEP, of course, is you basically need to be not taking it at all to get a breakthrough infection, right? So if you got infected, you weren't taking it. So the likelihood that you were going to get a masking of the infection by ongoing TDF-FTC use when you seroconverted was fairly low. Now, some people do take it intermittently, right? They seroconvert and then revert, or there's a break or a hiatus. So there was about a 7-day delay in diagnostic reactivity that was observed in the Partners PrEP study. So we knew that there was a potential of these anti-HIV agents both to reduce the viral load set point and mask the timeline of antigen and antibody formation in the use of these ART, but we did not anticipate the profound effect of a potent integrase inhibitor, much less a long-acting agent like injectable cabotegravir. So that was what was pre-specified that gave us those results. What we sort of found out when we poked around experimentally a little bit was one negative back test wasn't enough. Because cabotegravir is so potent, has such a high barrier to resistance, and the injectable form lasts so long, you could have intermittent detection of antigen and viral RNA. So finding one negative qualitative aptema isn't sufficient to determine the first evidence of HIV infection. The viral load, both quantitatively, qualitatively, and when you look back with antigen antibody testing, can flicker. It can be positive, then negative again, then positive, then negative again. And it can happen over a very prolonged period of time. So one negative isn't enough to establish the first detection of that infection. Why do we care? We'll get to that in a minute. So we did post hoc, created this additional algorithm that we then deployed. We kept the fourth generation testing, we kept the confirmatory testing, we kept the aptema testing, but we added quantitative testing. This was using the Roche M2000 platform with a lower limit of quantification of 40. And we didn't just stop at one negative. We back tested these cabotegravir PrEP failures all the way back to enrollment. So we looked at everything to try and get a sense of the pattern of viral detection and the antibody patterns. So people will remember this slide that I presented at AIDS 2020, where I bucketed the cases that we thought we had into these four groups. The A's were these baseline infections, right? So even though these people had negative RNAs before entering the study, when we did sensitive back testing, this green virus emoji shows where we were first able to detect the virus. So these were prevalent cases. They existed before any PrEP agent was administered, so they don't count towards the incident infections. So that doesn't count towards the 13 that I told you about. These B cases are cases that happened at least 6 months after the last dosing of cabotegravir. Now, in two of these cases, they never ever got an injection, as denoted by these cute little syringes here. B2 and B5, they just got oral drug and then disappeared. So that's not a shock that they seroconverted, right? What is fascinating is a lesson here about, you might remember that we've all hand wrung a lot about cover the tail, cover the tail, cover the tail, right? We've really sort of been very concerned that after the last injection of long-acting cabotegravir, there would be this really prolonged decay of cabotegravir in the plasma that at some point would no longer be protective, but if somebody acquired HIV during that period, they could still get cabotegravir and potentially pan-integrase resistant, right? And so we decided we must give somebody daily oral TDF, FTC to protect that period of vulnerability. So what we learned from this is even when you give people TDF, FTC, and you tell them to take it in that context, people who don't do well on pills don't do well on pills. They don't take it. So both of these participants here, B1 and B4, you can see they were given TDF, FTC with the little pill bottles and the blue shading. There was no evidence of any detectable tenofovir or its metabolites in plasma or dried blood spots in any of these samples. They never took, as far as I can tell, a single dose of the TDF FTC. So if you have somebody who's challenged by pill taking, they're not going to do well when you tell them they need to take pills anyway. Keep that in mind. We're going to talk about that when we talk about the oral lead-in and its sort of advisability. So the C cases were ones that occurred during the oral lead-in. We didn't detect them at the sites using that pre-specified testing until where you see the black asterisk, but the green virus emoji shows you where the HPTN lab was able to find evidence of the infection. And in all three of these, it was during the oral lead-in. So again, you could ask the question, were these people actually taking the oral drug? They could have faked us out with their pill counts, pill dumping. We see that all the time. And I will share with you, when we looked at the cabotegravir concentrations, C2 never took any cabotegravir ever. So not a surprise that they seroconverted. C1 and C3 did. And at least at the 2 time points at week 2 and week 4 during that oral lead-in that we were able to measure plasma cabotegravir concentrations, they were what you would expect them to be. Now, I can't tell you what was happening between those two discrete measurements. They could have been just faking us out and white coat dosing, but it seems a little provocative. And I wonder what people were doing not only with adherence, but if that oral lead-in period is a period of vulnerability, right? We know with tenofovir-based PrEP that there's a period, a timeline to onset of protection when you start dosing that has been modeled to look at sort of the time you get high concentrations in the relative tissue compartment, right? And we've estimated that for rectal protection, it's somewhere between 5 and 7 days. And there's an ongoing controversy about the cervical vaginal compartment, about what that comparative metric is, right? The CDC still says it's 21 days, but people who look at tissue PK carefully and do extrapolations think that it's actually probably about 7 days, and we don't really have good clinical data to back it up. But IAS USA did come out with a little bit of a provocative recommendation in 2020 that in order to get faster concentrations of TDF FTC PrEP, at least for MSM, when starting, to double dose your first dose based on the IPERGAID data, which did a rectal tissue substudy showing that if you double dose TDF FTC right up front, you get detectable rectal tissue concentrations at about 24 hours. So controversial, but raises this question of what is the timeline to onset of protection in the rectal compartment with cabotegravir? Don't know, but the partitioning of cabotegravir into rectal tissue is 8% of plasma. The tissue partitioning in the cervicovaginal compartment is 20% of plasma. So the relative tissue partitioning of male and female genital tract with cabotegravir is the flip of what it is with tenofovir. So one wonders if there is a longer onset of protection writ large with rectal tissue with cabotegravir than there is with Truvada. Don't know the answer to that because we didn't sample rectal tissue in 083, but provocative. And then finally, there were these extremely interesting 5 cases, we called them the Ds, where as far as we could tell, the injections were given on time and people seroconverted anyway. And people were scratching their head, what's up with this? What could this mean? What could this be? And we still don't have an answer, but I have some hypotheses that I'll share with you. But they're certainly the most interesting cases. So what happened next? So that was the pre-specified analysis. And then when we did this post hoc testing, which allowed us to use RNA testing and back test all the way back to enrollment for all these samples, keep your eye on D2 and D5 in the red boxes on this slide, because we have some animation, so buckle your seatbelt. Joanne, is your seatbelt buckled? Okay. So here comes the animation. This is what happened to the green virus emojis. You see that? So the D2 moved back about 2 months, who cares? But D5, it turns out, if you do RNA testing at the enrollment visit, guess what? It was a prevalent case. So D5 actually wasn't a D case at all. It was, in fact, A3. And when we did this on all of the samples, including the ones that weren't confirmed, we found, guess what? An A4, which was another baseline sample that was not detected on the pre-specified testing algorithm, which is why we presented at CROI 2021 these numbers. 12 incident infections, so that D5 went away from the incident count with this post hoc analysis. That none of the Truvada ones did this, and we did the same testing with the Truvada cases, and the hazard ratio was basically the same. I mean, the number is slightly different, but the direction and the magnitude, whatever. Take-home message is still the same. What did we learn from that, importantly? So the Group A cases, so these are the prevalent, the baseline cases, right? So when we looked at these, so if you don't figure out that somebody really is HIV uninfected and they are very early in that eclipse or window period and you start cabotegravir PrEP, it becomes incredibly hard to diagnose once you start the cabotegravir. And that includes the oral, because the oral, if taken with fidelity, does the same thing the injectable does. It masks that infection, it suppresses viremia, it delays antigen and antibody production, and in many of these cases allowed these people, even though HIV infected, to go on to actually get injections because the HIV infection was not detected. So that's an argument, number one, possibly against using the oral lead-in, but raises this question of, do you need to do an RNA the day you start cabotegravir? And that's what led the FDA and the CDC to say yes, because you can imagine what the resistance consequences are of taking somebody with HIV that's undiagnosed and giving them cabotegravir monotherapy over time. Correct. You get integrase class resistance. So the viral load is lower. It may even be undetectable. Aptima and RNA Aptima testing was the most sensitive test, but it's super expensive. At least the old test was. Joanne, correct me if I'm wrong. I think the new Aptima is priced to be very competitive with what she doesn't know. Bernie Branson tells me it's $13 a test, and coincidentally also has a lower limit of quantification of 13 copies. That's an interesting coincidence, isn't it, if it's true? So we'll see. But that was the most sensitive test to detect these infections, the earliest. Point of care rapids and fourth and fifth generations didn't really do a whole lot in terms of finding these. And if you fail to diagnose that infection, it can lead to continued CAB administration, even injections. And when you break through CAB monotherapy with these high concentrations, it will get resistant to cabotegravir. And what we found is first you get, not surprisingly, resistant to raltegravir and elvitegravir, and then you accumulate mutations and you start to get reduced susceptibility to dolutegravir also. So you want to detect these cases as early as you can, and you want to get somebody on fully suppressive ART. Whether or not you can use a second generation integrase in these cases, we have no data. I would be nervous about doing it. I would be most comfortable salvaging this with a boosted PI. So that's what we learned from the prevalent cases. We had one case, interestingly, that did not detect it. And then they stopped the injections, and we actually got to watch them decay. And then they became detectable on the site-based assays during the tail. Fascinatingly, not resistant to integrase. What? I know. So we hand-wrung about the tail. This, one swallow doesn't make a summer. One case does not exonerate the possibility that this could happen. But I was surprised. Virologists, not so much. They say when you get resistance is when you escape your viral replication with high concentrations. They say they wouldn't have expected us to get resistance when replication is occurring with waning concentrations because it doesn't put selective pressure on the virus to become resistant. It's low concentration, so why does it need to? Still doesn't make 100% airtight logic to me, but the virologists say they're not surprised. What about the B cases? What did we learn from them? Those were the ones that were like 6 months out from their last cabotegravir exposure. There's actually some, cognitive reinforcement of what you would have expected to happening here, right? So what we learned is the following. If you don't take CAB, it doesn't prevent HIV infection. That's good to know. In the 3 participants that we do have who didn't take it, and then they got HIV, their exposure was during the tail, they got wild type virus. So again, 3 swallows doesn't make a summer, but it certainly is reassuring that with these 3 tail phase infections, we did not see any integrase resistance. Now, does that mean it can't happen? Absolutely not. We need more cases. We're probably not even going to be able to answer this question definitively until this is in widespread use and we hopefully have a registry for this, because I don't think even the demonstration projects, the open label extensions, is going to be enough exposures in this context to really answer this question. It does not rule out that it will happen. And again, as I mentioned, in the 2 cases where people were given oral PrEP to cover the tail, no evidence that they take it. What about the oral lead-in cases, these C cases? What'd we learn? Well, we learned this. Surprise, If you don't take it, it doesn't protect you. We have no idea how forgiving oral cab is, right? That's one of the things we like to pat ourselves on the back, that we know with the most rigor for TDF FTC PrEP, right? 4 or more doses per week on average, we strongly believe has extremely high levels of rectal protection, right? We're very confident in that. We have no idea what the correlates of protection are for CAB to be able to estimate this. So the recommendation for when someone is using an oral lead-in is you got to be as faithful to daily dosing as you can be, because we don't know how forgiving it is or isn't. There is likely a time of onset, but we don't know what that is. So people need to be particularly careful during the oral lead-in period. And I'm going to be a little bit provocative here and say, we've all hand-wrung, cover the tail, cover the tail, cover the tail. I wonder if that's the wrong coverage question. Do we need to cover the nose, not the tail? Because if there is a liability to onset of protection, should we actually use the oral lead-in to overlap the first 4 weeks of injections, or maybe even try to leverage another form of oral PrEP during that onset period? I don't know. I'm going to be provocative and ask you to think about that. But we don't know how long that onset is. And if people do take it, and if cabotegravir orally administered delays incident infection detection by masking the assays, you can inadvertently give people injections, which then obviously can expose them to much longer-term cabotegravir, predispose them to resistance. But as with the A cases, the baseline cases, if you escape at high CAB concentrations, you get CAB and other integrase resistance. So those 2 cases I told you about where the plasma levels did look commensurate with daily dosing when we measured it, both got integrase resistance. So 2 of the 3 oral breakthroughs had integrase resistance. The 2 of 2 that had any evidence of taking the drug had integrase resistance. There's a theme there. Hold on to that. The D infections, these were the on-time injections, what we learn. So what we learned is massive delays in detection using conventional algorithms. CAB concentrations in the blood were all as expected when we measured them. So this wasn't some wonky pharmacokinetics, low-level breakthroughs with levels that weren't what they were expected. They were all as predicted in all 4 of these cases. So it's not some phenomenon of bizarre metabolism that led to these infections. And what we saw happens is the first thing that happens is low-level, I'm calling it smoldering viremia. So viral loads anywhere between single digits and about 150 copies for weeks, if not months, as ongoing cabotegravir injections happen, flickering on and off aptamas, flickering on and off detected below the limit of quantification quantitative RNAs, flickering antigen antibody tests. No one knows what to do with these results. Patients don't believe that they actually have infection. It's very hard to disambiguate false positive from true breakthrough infection without the longitudinal horizon of what happens next. And if you keep administering the cabotegravir, eventually that smoldering viremia breaks away with orders of magnitude jump in viral load. That's usually when the site detects it, and then you already have integrase resistance. So the $1 million question is, if you had done viral load screening all along, could you have, if you believed it, identified that infection earlier? Answer, spoiler alert, some upcoming data that we're going to be presenting, yes. But why do you care? And this is going to get to this whole guideline issue, right? Why should it be in our guidelines? In my mind, 3 possible reasons you would care about finding that HIV infection at that early time point of smoldering viremia. Number 1, does it have personal health benefit to the individual? Probably not. Are their T cells going to tank and put them at immune risk from this smoldering low-level viremia? Probably not. Are they going to go ongoing horizontal or sexual transmission to a partner? Probably not if the viral load's below 200 or these low-level smolders, right? So probably not that either. Third point, can you avoid the integrase resistance or minimize it by finding it early? Punchline to be presented at an upcoming major conference that I can't name because of embargo requirements, but might or might not be happening in the next couple of weeks, and those data might or might not be presented there. Yes. So that, to me, is an important finding that forces the hand of whether or not it's worth the squeeze to do the juice of using this RNA testing. Because if you can avoid impugning and compromising the activity of first-line treatment regimens globally, that's really important, right? Now, suppose viral load isn't available. Does that mean you shouldn't use cabotegravir? Well, that's a really important modeling exercise to try and ask the question, right? Because we have 66% fewer HIV infections in MSM and trans women, 90% fewer HIV infections in cisgender women in sub-Saharan Africa in our sister study 084. Does that, excuse the term, trump any delayed detection of infection and the need for use of second-line agents because of the vanishingly fewer cases that are going to actually happen when you use cabotegravir? So that's a really important question for the modelers that we need to still sort out. But the reason I so vehemently disagree with the CDC, with their recommendation for viral load testing in the TDF FTC arm, is they quote HPTN 083 data that similarly to these delays we saw with cabotegravir, which were a mean when it happened of 90 days. They quote a mean from 083 in the TDF FTC arm of 30 days. Now that's a biased mean for a number of reasons. So the median overall was 0 days delay, right? When there was a delay, because most people didn't have a delay, the mean delay when it did happen was 90 days, but it's administratively biased by when the next time you measured or you did HIV testing was, right? And in 083, we on average tested once a month. So we know from Partners PrEP there was an average 7-day delay from TDF FTC in conventional diagnostics. In 083, we didn't test again for a month. So if there's any delay, of course you didn't find it for a month. So of course the average when there was a delay is 30 days. That was sort of the minimum time you could find it if it was delayed at all. So okay, so there's a little bit of a delay. I ask again, who cares? Is there benefit to the individual at finding it earlier? Probably not. Is there benefit to transmission? Probably not. Is there an impact on resistance and impact on treatment? What's the worst thing that happens if you continue to administer TDF FTC when already infected? M184V, even worse, K65R and M184V. Can you salvage K65R, M184V with either Biktarvy or a TLD in resource-limited settings? Nadia and Dawning tell us, yes, you can. So do you care? Is the juice worth the squeeze of demanding RNA testing for screening for tenofovir-based PrEP, knowing that it doesn't matter? You're not going to change your treatment? And there's no benefit? I don't think so. And that's where I think the CDC missed the mark. So I'll get off my soapbox there, but that's my argument. And if you think I feel passionately about it, you're right. Anyway, so I need to say this bullet that I just put up there, but spoiler alert. So I just want to show you an example of what we saw. And let me just orient you, and then I promise I'll stop talking so we can have time for questions. So these are the plots that we did of the pharmacokinetics of cabotegravir and what happened at the site. So this is one of our most provocative cases. So the orange dots are cabotegravir concentrations. The dotted lines are the non-human primate correlates of protection. The top dotted line is 8x PAIC90, which was our pharmacokinetic target. The second from the top line is 4x PAIC90, which was ballpark, the non-human primate correlate of rectal protection. Below that, the third lowest one, the second from the bottom, is 1x PAIC90, and BLQ is below the limit of quantification. And the green lines are when injections were given. The red line is when the sensitive laboratory center testing found the infection, and the blue line is when the site found the infection. So here's a guy who enters the study. They have obviously no cabotegravir in their system at week 0 because they're just starting. Then at 2 weeks, they've got above 8x PAIC90. 4 weeks, that's the oral lead-in, still 8x PAIC90. They get their first injection, and then they get their second injection. Then they get their third injection, unbeknownst to anybody. They're positive at this point. They get their fourth injection, nobody's found the infection. They get their fifth injection, nobody's found the infection. And at the follow-up visit after that fifth injection, the site finally catches the infection on the fourth gen. When you look back at the testing platform that was done at the lab, and it's up here, you can see that a sensitive viral load test would have caught it back here with the 860 at that third injection time point. Or if they had done an Aptima, it would have found it also. But it's just kind of crazy if you look at what's happening to the quantitative viral loads, right? It goes from 860 to not detected to detected less than 40 to 112, and then it sort of escapes an order of magnitude up to 7,000, and that's when the site finds it. So it's kind of crazy. And, punchline is, yes, this had integrase resistance when we genotyped these specimens when the site finally detected it. And I can't figure out if I have that animation here. Yeah. So this person actually got transmitted K103N. We were able to say that. And what's nice about that is we were able to genotype this first specimen and say there weren't integrase mutations here, but by the time it breaks through, they have R263K. And, we're seeing a wide variety of different integrase mutations. We're seeing Q148K, Q148R. We're seeing N155H. We're seeing this 263K. They're pretty scary mutations that you don't want if you're going to try and salvage with an integrase-based regimen. So what the majority of these patients and participants ended up going on was either a boosted PI regimen, or if you can do a genotype and show that there isn't K103N, you can use an NNRTI-based regimen. So that's an option also if you have genotyping capability. But there are no data to date of these CAB PrEP breakthroughs being treated with dolutegravir or bictegravir, so I don't know if that works. Just to mention it, because I already sort of did, just want to remind people that there was a very similarly designed study in cisgender women in sub-Saharan Africa, our sister study called 084, and it showed a 90% reduction in HIV incidence in the CAB compared to the TDF-FTC arm in those women. And so I expand this concept of PrEP 3.0 to now include cabotegravir with these two results. And you can see the dramatically low incidence rate in the cisgender women in sub-Saharan Africa, where the incidence rate could have been as high as 6 or 7%, down to 0.21% in the cabotegravir arm, which is, in my mind, an even more exciting result than 083, given the failure to find effective biomedical prevention strategies for cisgender women previously. So I think that's super exciting, and that the approvals are coming, and that the non-US regulatory submissions are already in progress in South Africa, Australia, a lot of the other countries in sub-Saharan Africa, and Brazil. So stay tuned for that. And then we can talk probably, if people are interested, about the Mayday level drama going on with some of the other long-acting PrEP agents that we were previously so excited about, islatravir and lenacapavir in particular, that both are on FDA clinical hold at the moment for different reasons. But so this is going to be the long-acting agents that we have for the moment. And I will stop there in the interest of hoping I have time for questions, but I just wanted to really recontextualize these data with a lens of why the FDA is requiring this RNA testing and why I disagree with the RNA recommendation for tenofovir-based PrEP. And I'll stop there. Thank you so much for your attention.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.